This one I bring to your attention because of how important it is to make sure you're using the right descriptors. The diagnostic statement says irritant contact dermatitis due to cosmetics, but if you look at your index, it'd be very easy for you to pick up on the H codes and not the L code. But the difference is that irritant, the descriptor adjective irritant. That is very important in the assignment of the code. So I've put in a red font here so you can see what I'm talking about. But I also want you to notice under the L24 category code there is an excludes 2 note for dermatitis of the eyelid, and those are those H codes. So since it's an excludes 2 note, that means we could code both the L code and the H codes if the patient had both conditions, a dermatitis due to an irritant and a dermatitis due to allergies. How a doctor would know the difference, I have no idea. But the code book tells us that because of that excludes 2 note, we could code both at the same time. Stevens-Johnson syndrome with toxic epidermal overlap syndrome with skin exfoliation 10% of body surface. Stevens-Johnson syndrome and the erythema multiforme disorders are the saddest things. They are, the patient just has these boil-like and burns and excoriation all over their bodies, and they just suffer tremendously. In this particular one, there is an instructional note that tells us to use additional code to identify the percentage of skin exfoliation. So I wanted to make sure you were aware. Once again, we're going to always look at those additional codes, use additional code or instructional notes, and make sure that we would code that exfoliation. Because of the type of disorder this is, that exfoliation is where the body starts to really, the skin is breaking down and you've got it just peeling, and the percent of body surface area would give the physician a very good idea of what they're dealing with. So it's just important to follow those instructional notes. This is an example of a pressure ulcer. Early in the PowerPoint, we coded a non-pressure ulcer. And I bring this one to your attention because we are able to use the nursing documentation that stages these ulcers when we are coding. And I've quoted here the general coding guidelines, 1B14, which is stating that documentation for BMI, non-pressure ulcers, and pressure ulcers, code assignment can be based on medical record documentation from clinicians who are not the patient's provider. You may remember back when we were coding BMI, or body mass index, we were using the nurse's documentation for the patient's BMI. So here we go with the skin, the non-pressure and pressure ulcers. We can also use the nurse's documentation for the staging because that is part of our code selection. So I have the pathway here on the right, and you can see how I got those codes, and then the rationale we'll look at on the next slide. But I did want to bring to your attention this note about instructional note for the L89 category. You are going to code first the gangrene because that's your most serious thing you have to deal with here. Gangrene, if you don't know, is just dead tissue, and it is not a good thing when you start having dead tissue in these ulcers. It takes a lot longer for them to heal, to fill back in. So here's the rationale for the previous slide, that decubitus ulcers are classified as pressure ulcers, and the note at the beginning of category L89 indicates that sequencing. What we just talked about, the gangrene would be first, then your pressure ulcer of the hip, looking at always going to the tabular to make sure you're selecting the right code when you're indicating the stage and the laterality. And then the sacral region is stage 2, and the sacral region includes the tailbone and the coccyx. Now, actually, the tailbone to me is the coccyx, but that's what the source I was using here made a distinction between those two things. To me, they're the same thing. I wanted to bring this one to your attention because when you start looking in the code book, in the index, when you get into atherosclerosis, it gets very busy. And you really have to watch your indentations in the index so that you go to the right one. And there's a pathway. On the next page in the rationale, I mentioned that the bypass graft codes of the extremities are listed first. So you really have to keep reading down and watching your indentation until you get to the leg, and then you can locate left or right. Also, at the I-70.23, there is an additional code to identify the severity of the ulcer, and a code first any underlying conditions. So you can see where we, in the previous slide, we did code that arteriosclerosis first, and then our ulcer code. And it's telling us that we could use the L97 code as a principle if no underlying cause had been documented. But because we did have the arteriosclerosis documented, then we're going to sequence that first, and the L97 would be a secondary code in this case. If you have a condition like arterio or atherosclerosis of the lower extremities, or chronic venous hypertension, diabetic ulcers, post-phlebitic syndrome, varicose ulcers, that condition, you can assume that there's a relationship between the ulcers and those causative diagnoses would be sequenced before the ulcer codes. Okay, the next one, infection of a nephrostomy site. I make a little note here that you know a nephrostomy and a urostomy are two different openings into the genitourinary system. The nephrostomy is with the upper part of the kidney, which is the renal pelvis, and the urostomy is lower down in the urinary system. It could be a lower part of the kidney or the bladder. But both of those created openings are to allow the body to drain the urine, and it typically would be done whenever there's been insult to the kidney, or it could be a malignancy. For whatever reason, the body's not able to empty the urine the normal way, the way that we would be able to do that. We create these stomas or openings in the body that allow us to insert tubes, and then the body, the urine can be drained from the body. The kicker here is that you really have to convert that diagnosis of infection to complication to find this code. And I would say the more you code, the more you're going to find out when you read something, it says infection, but it means complication because it's a procedure. A nephrostomy was a procedure that was done to the body, so it would make sense that it would be a complication code. And then when you go, there is no infection to a nephrostomy, no infection for a stoma, so then that would again make you consider the possibility of using complication as your main term, and then going down for the stoma. And when you finally get to it, there is an infection as a subterm that allows you to find this code. Okay, as always, be mindful that the exercises in this PowerPoint do not address all of the guidelines. Exam questions will relate to all the guidelines covered in the chapters planned for each week, not just those guidelines covered in the PowerPoint. Always follow the assignment schedule with regard to specific chapter assignments. If you have any questions, please post them in the discussion board, allowing me to see the path that you used to try to find the code, and then we can let everyone share in our discussion. Thank you so much and have a good week.